Snyder, the Senior Vice President for Advocacy at the MHA. With me today, Bob Riney, the President and Chief Operating Officer of the Henry Ford Health System, who will offer the MHA and Henry Ford Health System testimony today.
And one of the individuals that we lost without his glasses today, but thank you, Chairman Molinar and members of the subcommittee for the opportunity to testify on the community health budget. I am Bob Riney, I'm President and Chief Operating Officer of Henry Ford Health System, and I've been with the system for 32 years. Henry Ford owns and operates 6 hospitals, 27 medical centers throughout southeastern Michigan and Health Alliance Plan. Our medical staff consists of 1,100 members that are a part of a Henry Ford medical group or group practice, as well as 2,100 private practice physicians. We're one of the largest medical workforce training programs in the country, with more than 650 residents, and the nation's largest osteopathic physician training program in the country. We serve approximately 1 million patients in the region, including Medicaid, Medicare, Blue Cross, and uninsured. I serve on the board of the Michigan Hospital and Health Association, and I'm here today to represent all 140 hospitals who are members of the MHA. And briefly, I want to just cover several main points. Number one, we believe Governor Snyder's decision to avoid further cuts to funding for Medicaid health services is the right thing for Michigan, and we urge adoption of that approach. Secondly, we fully endorse his plan to establish a dedicated fund for the Medicaid program supported by a 1% tax on health insurance claims, and we urge you to approve the important feature of the governor's overall budget and tax package. We have, however, grave concerns about the 40% cut to the physician workforce funding that is represented by reductions in Medicaid funding for graduate medical education. We urge you to find a better way to achieve the $22 million in general fund savings that would come from this 40% reduction of GME. Today, nearly 20% of the Michigan citizens rely on Medicaid for their health care needs. The number of Michigan citizens, as illustrated by Steve Fitton, without health insurance of any kind recently increased to 1.35 million residents. Taken together, it means 3 million people, or 30% of our state's population, are either enrolled in Medicaid or uninsured. Because of this very difficult economy, Michigan has struggled to support the needs of the citizens who rely on Medicaid, with the loss of 1 million jobs over the past few years and the extra pressure that is put on Medicaid as a statewide safety net for so many families in our state. To help respond, Michigan hospitals, nursing homes, and HMOs currently tax themselves to supply state money that is eligible for federal matching funds. Due to provisions adopted by Congress, federal Medicaid match has been generous for the past several years. For every general fund $1 for Medicaid, the federal government has provided $2.75. In July 2011, the match rate reverts to a formula that provides $2 for every $1 of Medicaid state dollar. Because of the voluntary tax that hospitals and other Medicaid providers pay, the vast majority of state funds currently come from the voluntary provider taxes and do not represent a drain on Michigan's general fund. We have stepped up to the plate in this way because we share, quite frankly, the obligation for our communities and for our families during this time of economic upheaval. While the executive budget does not institute new reductions, it does carry forward provider rate cuts from previous years. This means that Michigan hospitals will continue to tax themselves to cover the 8% cut that was first imposed in fiscal year 2009. I'd like to turn for a moment to the 1% health insurance claims tax. Although only one other state in the country, New York, has instituted a tax-supported Medicaid fund, we believe that, quite frankly, this is a brilliant strategy to address the current funding needs and to establish a fair and equitable revenue source for Medicaid going into the future. The tax will generate an estimated $400 million per year, which makes Michigan eligible for an additional $800 million in federal Medicaid matching funds and produces, as Steve Fitton articulated, a total of $1.2 billion for the Medicaid program. This has all the hallmarks of what experts believe is good tax. The revenues provide a dedicated and reliable source to attract federal Medicaid matching funds for state-supported health care needs. The tax is broad-based, it's not narrow, it's not targeted to just a handful of taxpayers. Everyone pays and everyone pays the same. The tax is fair and employers receive relief in other parts of the governor's tax package. And the tax is responsive because tax revenues will increase with healthcare costs, allowing revenues to keep up the cost growth in the Medicaid program. It's also important to note that the tax replaces the Medicaid HMO tax that the federal government may disallow. In the absence of this new revenue source, the state faces a $1.2 billion cut to the Medicaid program, which hospitals, physicians, and quite frankly our communities cannot sustain. On behalf of my colleagues in the MHA, we urge you to approve the 1% insurance claims tax as an important investment in the well-being of our citizens and the future of our communities, and quite frankly, some predictability. And I tell you, as president of Henry Ford, I say this with a little bit of hesitation, because it will cost our own Health Alliance plan, our own insurance company, $17 million per year with no exemptions or no offsets. But that said, we believe it is the right policy for the state and are supporting it. As I mentioned at the beginning, we have grave concerns about the 40% reduction in support for graduate medical education. This actually would harm one of Michigan's most successful enterprises, basically killing the goose that is laying the golden egg. Medical workforce training programs are part of an academic enterprise that holds great promise for Michigan's role in building the new scientific and innovation economy. Currently, we are the nation's third largest supplier of physician workforce training, behind only New York and Pennsylvania. Our Michigan teaching programs help Michigan avoid and cope with physician workforce shortages. At Henry Ford, 40% of our physicians join the Henry Ford Medical Group directly from graduate medical education programs, and many stay in their careers in southeastern Michigan or elsewhere in Michigan for 30 to 40 years. At the same time, our residency programs attract the advanced degree workforce Governor Snyder wants to build in Michigan. This advanced degree workforce are the people who will bring research dollars to Michigan and partner with manufacturing and product development firms and venture capitalists to generate product for our new economy. At Henry Ford, we have $60 million in federally funded research grants, and the University of Michigan Detroit Medical Center and others have large research programs. This is money that does not come to Michigan without the advanced degree workforce. This research gets translated into products that have customers that pay for those services, such as the Medical Radiation Countermeasures Project at Henry Ford, that is quite frankly right now bringing to market a drug that the Department of Defense will use against terrorist or military radiation exposure. It will be a profitable venture for the state. Another example is the very successful robotics programs that were generated out of our successful advanced degree programs. In addition, our physician workforce contributes jobs and spending at the local level. It's important to know, and this is according to the Graham Center, a family practice physician generates 8 to 10 new jobs, $1.7 million in spending for housing, retail, and other economic activity, and $1 to $1.5 million in health services economic activity. The connection between workforce and the two health indicators Governor Snyder has indicated on his dashboard is self-evident. Physician shortages currently handicap our efforts to reduce infant mortality and obesity, two of the governor's priorities. Medical residents significantly extend the ability of physicians to provide primary care, especially in shortage areas like Detroit and southeastern Michigan, where quite frankly both the obesity and infant mortality rates are very high. The $22 million in savings from the medical education cuts are really a $69 million cut, because the reduction of our federal match has to be factored in. This is the wrong time and the wrong place to seek such small savings at, quite frankly, such a great price. Targeting medical education hits 15 hospitals in southeastern Michigan, which stand to lose $46.2 million of the total $69 million that would be lost to this workforce-generating enterprise. And quite frankly, if I could make one point that hopefully would resonate with you, is we have a lot of medical schools that are growing or expanding in the state, and that's a good thing. But that will not generate an economic return on investment, because where an individual goes to medical school does not dictate where they will end up practicing. Where they do residency is the main factor of where they will end up practicing. So if we have fabulous medical schools, but we do not have the funding for a robust residency program, those individuals will take advantage of the education system in Michigan, and they will practice elsewhere because they will leave the state for residency and they will end up setting up shop in other states than Michigan. So from a return on investment in education, it's the residency programs that are going to generate the economic return for Michigan. Thank you for your attention.
Thank you very much. And Senator Caswell.
Thank you. Thank you for being here today. I asked this question earlier to the department. Is it possible to differentiate between the graduate medical education program and the primary care GME? I know they're cutting one, they're adding to the other, and so on. Is that even reasonable to do? Can you do that?
I can't speak to the statutory issues involved, but from a provider standpoint, absent barriers in the statute, we could do that. I would have a couple of cautions to that. One is, if you look at the impending workforce shortages that will happen in the next 5 to 10 years, we're going to need graduate medical residents training in almost every specialty in the clinical field. So kind of cutting one area to create focus on another area may help in the short term, but it's not going to help in terms of the long-term shortage of physicians that we have in the state. And the second point that I would make, and I'm going to go back to economic drivers, is in all your clinical specialties, what attracts the best and brightest physician and scientist leaders and chairs to academic organizations are in part the ability to teach residents. And absent residency programs, they will not come into those positions, and they are the ones that are working with venture capitalists on the creation of new product and generating economic activity in the state. So these are not separate and distinct activities.
Thank you.
Senator Gregory.
Thank you, Mr. Chairman, and thank you for the testimony. My question is on the 1% health insurance claims tax, and you represent 140 Michigan hospitals. Is that, so are they all on board with that, or some are, some aren't?
We haven't had an opportunity, Senator, to take it to the full membership of the MHA, but the executive committee of the MHA Board of Trustees have voted to support the claims tax proposal. And as Mr. Riney outlined, hospitals as employers will also pay that tax.
Good. Just as, and one other follow-up, I probably saw it in here, but you gave some estimates of how much it would generate. Is that, I've heard some different, I guess, different numbers as far as how much money this would generate. Do you, are your numbers pretty solid, or?
What I can tell you, Senator, is we have worked with the department on this, as well as Rick Murdoch at the Michigan Association of Health Plans. And the best numbers that we are working with today are the numbers that Mr. Fitton presented earlier. Tax raising about $396 to $400 million, and essentially a federal match, which would double that, $800 million, combining the two, the $1.2 billion. That lacking this funding alternative, we are very frightened about the impacts of what would happen to the healthcare community if the money was not done.
Thank you.
Thank you. Seeing no further questions, thank you for your testimony.
Thank you very much.
Next, I'd like to invite Steve Minnick